Recently, Dr. Kara Dupuy-McCauley, Section of Pulmonary Critical Care and Sleep Medicine at Mayo Clinic, and SASM Communications Chair, sat down with Dr. Richard Schwab, Professor of Medicine in the Department of Medicine of University of Pennsylvania and the Chief of the Division of Sleep Medicine, to talk about his keynote session, Understanding the Improvements in OSA with Weight Loss Medications. Dr. Schwab will be presenting this keynote session at SASM's 14th annual meeting, October 18th in Philadelphia. Let's listen.
The data that we have so far, it seems like it's suggesting that you can get a really good benefit with respect to the AHI reduction with weight loss via diet and lifestyle modification or invasive surgery. But it seems like the GLP-1 agonists are turning out to be a huge breakthrough in the management of obesity, and they're becoming more common. And so I'm really happy that people are looking into their impact on, other diseases like sleep apnea. The first thing that I wanted to ask you is just, were you involved in the conception of this study? And if so, how did the study come to be, and what was the motivation behind wanting to do this, rather innovative study looking at weight loss medications for treatment of sleep apnea?
First, Kara, I'm glad I'm here. Thank you for inviting me. I do think from a big picture standpoint, before I answer your question, the GLP-1s are going to be game changers in how we manage sleep apnea. So it is kind of this brave new world. Things are changing rapidly, and it's really kind of exciting. I was not part of the initial study design, but I know the study design well. I think they did a really good job of looking at people on tirzepatide and looking at placebo controls and seeing what happens in people who are not on CPAP. So these are patients with severe apnea, the apnea-hypopnea index, which is the measure for sleep apnea. The audience isn't aware, and it's just the number of airway closures per hour. But on average, the patients were pretty severe. They had an HI in the 50 range. And the first arm of the study was just looking at people who are not on CPAP, what happens after 52 weeks of weight loss with either placebo or tirzepatide. And the second arm is they used people on CPAP. They took them off of CPAP at the time for their sleep study because the CPAP would have affected it. So they were off for 7 days. And they tried to do that because it's a real world. They were saying, okay, well, there's going to be people who don't use CPAP. There's going to be people who do use CPAP. Does tirzepatide work in either or both or differently? And so I think that was the concept of the design, make it kind of real world, applicable to patients on CPAP or not on CPAP. This was not a head-to-head trial against CPAP. This was just to see if tirzepatide works either in patients not on CPAP or those, when I mean works, reduces your HI in patients either not using CPAP or using CPAP. But it wasn't the study to ask the question, is tirzepatide or a GLP-1 agonist better than CPAP? That's not what they were asking.
Yeah, I really appreciated the fact that they did two different trials, for people not on CPAP and for people on CPAP, because as you said, I thought it was a really, great idea to kind of try and represent more of a real world situation. Because, a lot of the studies that have been done in this area are, maybe just looking at the people who aren't on CPAP or didn't want to do CPAP for one reason or another, which obviously, skews the results because you're looking at a specific population. And so I really thought that was awesome that you guys did two different trials. There's a lot of data out there that does suggest that sleep apnea is responsive to weight loss, obviously. That's been shown over and over again. But I'm really interested about weight loss with medication specifically, and weight loss with this group of medications. There's some signals about the GLP-1 agonist, reducing inflammation or, having some other effects on the body other than weight loss. And so one thing I wanted to ask you about, and this might be hard to answer, but do you think that it's just the weight loss that's improving the sleep apnea, or do you think that there could be other effects of tirzepatide, like reduction in inflammation or something like that, that's maybe having, an additional effect in improving the sleep apnea?
That's a great question. I don't think we know the answer. I do think that I think it's pretty fair to say that the reduction in weight by itself on the upper airway, the pharynx, is going to have a huge effect. So the primary risk factor for sleep apnea is obesity, right? So obesity is the most common risk factor. And if you even listed the 10 most common risk factors for sleep apnea, obesity would be the first 10. And then there would be things like big tonsils or craniofacial restriction, small jaw. And obesity clearly has, and when you get heavy, you don't just get heavy in your abdomen, you get heavy everywhere, right? So your tongue can get larger, your soft palate can get larger, the lateral walls will get larger. And we published a paper in 2020 looking at apneics losing weight, but not with GLP-1 agonists, but just with bariatric surgery or with medical, just lifestyle interventions. And there was about a 15% reduction in weight, whereas tirzepatide is more on the 18 to 20% reduction in your BMI. And what we found was slightly similar to the SURMOUNT OSA trial. We had slightly over a 50% reduction in AHI on the order of 40, on average 41 down to about 19 events per hour. But the factor that mediated that change in AHI were reductions in tongue fat. Now, we have no idea if the GLP-1s are going to do the same thing, but that was clearly an anatomic effect. There was tongue size went down, tongue fat went down, and their AHI got better. And the primary mediator of that improvement was reductions in tongue fat. We don't know if that's the same for tirzepatide, but I think it probably will be, that there'll be reductions in anatomic size of these structures. We do know that the GLP-1 agonists, as a negative outcome, is they can reduce muscle mass, right? So they can reduce your biceps or major muscles. But for sleep apnea, that could be a really good thing. So not only may it reduce tongue fat or fat in the soft palate, but it actually may reduce the size of the muscles in your pharynx. So reduce the size of the tongue, reduce the size of the soft palate, reduce the size of the lateral walls, and all that would make it better. That all being said, I would bet, and again, I'll just put my nickel down, that most of this is an anatomic effect. But there may be other effects. We don't understand GLP-1s. There haven't been that many studies in patients with sleep apnea. Could there be inflammation? Yes. Reductions in inflammation. The GLP-1s, in some ways, are going to be, I think, the new statins. They're going to be used for lots of things. We already know that it helps hypertension, it helps obesity, it helps diabetes, it seems to help substance abuse, it's going to help sleep apnea, and on and on. So I think there will be other effects. And why does substance abuse get better? Why does that problem get better? That's not an anatomical change, at least not that I know of. So I do think there is, again, a little bit of unknown, but just reductions in obesity itself are such a game changer for patients that these medications are going to be used.
Yeah, and you guys did measure high sensitivity C-reactive protein in the study as well as an outcome. And so I was kind of wondering if that's, maybe where, the thought was going is, is this something that's going to have a big impact on inflammation? And is that somehow related to reduction in sleep apnea as well?
So we did, and there was a big reduction in high sensitivity CRP. I just think it's a kind of a non-specific finding, and I just don't think we know yet. I mean, there was an interesting study by Chirinos. He was a cardiologist at Penn, and some of the other physicians who I work with at Penn were on this paper. I wasn't. And this was a New England Journal of Medicine paper from 2014. And what they did, they didn't look at GLP-1s, but they looked at patients with sleep apnea, looking at cardiovascular outcomes, including CRP. And they looked in three groups. There was a group that used CPAP alone, a group that just underwent weight loss, again, lifestyle interventions, and the group that did both. And what they found was that the combination of CPAP plus weight loss was the most effective group in terms of reductions in cardiovascular risk, whatever outcome they were looking at. And we may find the same thing here, is that CPAP plus a GLP-1 will eventually be the best treatment for patients with sleep apnea. I don't think we know that yet. And, it's hard because these aren't long-term studies. These are, studies of 52 weeks. You need to sort of look longer term, I think, for cardiovascular risk. But I would agree with you that it's really encouraging that you're seeing improvements in cardiovascular markers with these weight loss drugs.
Yeah, that's I think that's one of the most exciting aspects to me too, is that, you're getting the benefit of weight loss, but are there, going to be other benefits as well that we haven't even pinpointed yet? Um, One thing actually that you said though about the anatomical aspects of weight loss and changes in muscle mass. So, I was just thinking about myofunctional therapy and, this is kind of starting to become, I think, more of a talked about treatment, or, at least around here it is. This is kind of focused on improving muscle strength or muscle endurance. If you're losing muscle mass, is that going to work against you as far as, robustness of the musculature that's controlling dilation of the upper airway?
I do think now you're talking to someone, I mean, my whole research career has been looking at upper airway anatomy. And so I am a very big believer in upper airway anatomy being the risk factor for sleep apnea. I do think, we published a recent paper looking at what happens when you go off to sleep, and muscle tone goes down. But I think it goes down in normals and it goes down in patients with sleep apnea. I'm not sure we're all programmed differently. But I think the issue is that you start off with anatomical risk factors for sleep apnea, whether that's a big tongue, whether it's a big soft palate, large lateral walls, small jaw. And by the way, the combination of a small jaw and big soft tissues is a recipe for disaster. So if you have that combination, you're going to have worse apnea. But I do think muscle function probably does matter, but I don't think we know, and we don't have good ways of measuring it. We do this EMG, electromyogram, which is not really a measure of mechanical movement. It's just an electrical sort of charge or signal, and so that's hard. So we don't really know how to measure it. So I don't know. I think you're going to find that reductions in muscle mass is I don't think the muscle is going to not work. It can, if you reduce your bicep size, if you weight train and you get a stronger bicep, you do it. But if you then lose that muscle mass, your bicep still works. Just you can't lift as much weight. And I don't think sleep apnea is that problem. It's more about reductions in tone and your airway moving backwards, in terms of the tongue moving to the pharynx, the lateral walls moving in. So I think understanding the mechanisms, how it's going to work, would be fascinating. But I don't think the reduction in muscle mass, which by the way isn't going to be that great. It's not like you're going to lose 50% of your tongue. That's not going to happen, right? It's going to be 5-10% of the muscle mass. I don't think it will have any effect that way. But if you talk to somebody else, they might differ, might disagree, but I think it's mostly going to be anatomical.
Oh, and that just made me think of something else. So this other medication, 8109, which is being looked at for treatment of obstructive sleep apnea, is kind of targeting the muscles of the upper airway. Is that like an opportunity to combine with tirzepatide for a synergistic effect and maximum optimization of the upper airway?
What you described is using 8109 in conjunction with another therapy. So your HI gets reduced by 50% with a GLP-1, but you started out at 50. Now you've got an HI of 25. You're a lot better, but you still need further to go. So in conjunction with other therapies, I think 8109 could be very helpful, especially people with hypoglossal nerve stimulation who aren't completely treated, people with oral appliances who are not completely treated, people, again, with weight loss that's not completely treated. So I do like it potentially in combination. I think those studies need to be done. So we'll see. And I think it's a little early on 8109 in terms of I don't think there's been a phase 3 trial that I've seen yet. I think it was only the phase 2 trial.
Yeah, I mean, medications kind of seem to be, one of the new hot topics in treatment of sleep apnea. There's some devices coming out, but it doesn't seem like there's that many, and there hasn't been a whole lot of excitement about any external device since CPAP, I don't think. But as you're thinking about using medications specifically for treatment of sleep apnea, what do you think are the next steps as far as research is concerned? Are we going to start looking at other GLP-1s? Are there other classes of medications? What would you think is going to be the next thing that we're looking at?
I do think there'll be other classes of GLP-1s. I think that's pretty clear. There's sort of newer versions which are going to be greater weight loss. I think it's probably fair to say that 75% of patients with sleep apnea are heavy, but maybe 20 or 25% aren't, and the GLP-1s aren't going to be useful, aren't going to be as useful there. I think that's pretty clear. I kind of disagree with you about the devices. I think hypoglossal nerve stimulation is a huge intervention where people can't tolerate CPAP, right? And I think that area is growing and there's new devices coming out. And I think you're going to see in time less invasive versions of that, maybe not even non-surgical approaches that will stimulate the hypoglossal nerve, which I think will be super cool. I think medications specifically for sleep apnea, not ones that are for weight loss, I think we're pretty far away, probably 5 to 10 years away from real medications that treat sleep apnea. The other thing that is concerning to me a little bit is that will doctors, especially general internists, take people off of CPAP and start using medications for sleep apnea that maybe aren't as good and aren't as effective. And then 3 years later, the patient has hypertension or has a heart attack or falls asleep driving because their sleep apnea was partially treated, whereas with CPAP, it was completely treated. And so I do worry a little bit about the whole medications and how the physicians will handle it, because once it's approved, a doctor can use it and will say, okay, you know what, let's take you off the CPAP and see how you do on this. And unless you repeat the sleep study, you're not going to know if their apnea is really treated. So there's a underlying concern I have here in terms of making sure that if you're going to take somebody off what would be the gold standard CPAP, or a different story if they're not using it, but in somebody who's using it, you better have a treatment that works as well. Or you need to make sure the patient's aware that they're going to be on potentially a suboptimal treatment.
Sure. I didn't mean to imply that I was not excited about Inspire. I was more so referring to non-invasive options, because I feel like implantable devices are like a whole other subjective conversation.
Let me just add one comment on that,
Go ahead.
which I think is super cool. I mean, the really neat, one of the neatest things about Inspire, it's reversible, right?
Yeah.
If I take out your gallbladder, you can't put it back. If I take out your soft palate, you can't put it back. This device, you can take it away. Now, it takes some work. It's not super easy. You have to remove the electrodes from the hypoglossal nerve. But I mean, in some ways, yes, it's invasive, but it's 2 hours of surgery and it's reversible, which is something that 99% of surgeries aren't. So I don't see it quite in the same way, but I understand what you're saying.
You kind of led that conversation to where I wanted to go next, which was clinical practice. This is going to be probably causing a lot of changes in how sleep medicine doctors look at treating sleep apnea. And also, as you mentioned, other people who are not in sleep medicine, family medicine providers and internal medicine providers. I think we are kind of starting to talk about that here in our sleep center and just wondering, do we have the infrastructure and the availability of follow-up appointments to, monitor people? Should we prescribe them medication for obstructive sleep apnea? And so, there's all sorts of questions like that. And I was wondering, how you or what you have been talking about in your institution as far as how this is going to change practice of treating sleep apnea in the sleep center. I guess a separate question is, as you mentioned, are people going to be not referred to a sleep center? As home sleep apnea testing is becoming more available and other providers who are not sleep medicine doctors are able to order that, are they going to be taking over treatment of a lot of our sleep apnea patients? How do you see this changing our practice?
Those are great questions. Again, it's a little bit of a brave new world, so I don't think we absolutely know. I'll start with the latter piece of this. I don't think you're going to see most doctors not referring you first to the sleep centers, because many of these patients are still going to be on CPAP, and general internists really don't deal with CPAP very well because they don't download the data. They don't really know how to do it. And so I think it's not going to be like insomnia where general internists prescribe this, because they're going to need another sleep study. A lot of these patients are going to come off of the medication, they need to go back on CPAP. I think it's going to be very difficult for general internists to manage sleep apnea from a GLP-1 standpoint. I don't think there will be a reduction in number of patients. I think you're going to see sort of direct-to-consumer advertising. If there's indications here, more patients are going to even come into the sleep center, and I don't think there'll be enough of these medications that sleep apnea totally disappears. I'd be surprised about that.
Mhm.
In terms of the practice, we have not started to prescribe them, but we are in process. I think once I do believe that Lily's going to get an indication for tirzepatide for sleep apnea, and I can't imagine any sleep practice not prescribing it at that point, because just like a narcolepsy medication, I mean, the patient's going to come in and they're going to say, wait, this medication is approved for sleep apnea and you're not prescribing it? That doesn't work. So I think almost all these practices, it may be you're going to be forced to, once there's an approval, and right now you don't probably have to do it, but we're all going to have to do it. But you also made a really good point. We have an access problem. We have a very big sleep center. We have 20 providers, 20 MDs, 10 nurse practitioners, 10 to 11 nurse practitioners, and it's still a month to see new patients. And the health system really wants that down to 2 weeks, and sometimes it's longer depending on who you are. It may even be more than a month to see you, maybe 6 weeks. So now let's say we start prescribing the GLP-1s in 80% of our patients. Well, we have to see those patients and follow up. And now we can't see new patients, so our access becomes worse. And we've talked about doing that. And I think the way you fix that is you hire more nurse practitioners to potentially see these patients. You do sort of telemedicine visits in a very short period of time, because a lot of the visits are really quick. You're doing fine, but you're going to change your dose, and we can do that in 10 minutes. So that's sort of how we're going to approach it. But if we kept everything the same, didn't add people, didn't make shorter visits, we would have an access nightmare. And there's the other piece of this is that it is hard to get them approved. And so we need pharmacy to be we're working with Penn's Pharmacy to make sure that we can actually prescribe these medications and get them approved. And then there's other issues about getting certain doses and different things. So there's some real issues related to this, but I think every sleep center is going to have to deal with it, and we're going to move forward and start prescribing them.
Yeah, we're just going to have to figure things out as we go along too. And I think everyone's going to need a really robust prior authorization department.
Correct. Here's that.
As we look into the future in a post-tirzepatide approved for sleep apnea world, one of the questions that I have is endurance of the effect, because there's a lot of information about weight loss and its effects on sleep apnea out there. We know that a very low-calorie diet will cause you to lose weight. We know that surgery will cause you to lose weight. But what seems to be the missing piece of the weight loss puzzle so far is, how do people keep the weight off? Because that's really, I think, been the sticking point for most weight loss methods, is that, yeah, they work while you're doing it. But when we look at people, 1 year, 5 years, 10 years down the line, the weight gain starts to come back. And that's also one thing that people have really been talking about with the GLP-1 agonists, is that, what happens when you stop taking the medication? Do you think that being on a medication for weight loss, is that going to make keeping the weight off easier, or is it going to create additional challenges, with people kind of going on the medication, going off it, going back on? Do you have any thoughts about weight maintenance, I guess is what I'm asking?
I do. I do think that's kind of the elephant in the room type of a question. And will people, first of all, how long will they stay on it? If they stop it, will everybody gain weight back? There's all kinds of fascinating questions of how they lose the weight and what happens. But I think if you think about hypertension, right? If you think about and let's say somebody doesn't lose weight, you're treating hypertension forever. They're maybe something will change down the line, but you're typically on antihypertensives your entire life. Why is obesity different? Why do we think about obesity as a 6-month trial or a year trial? I mean, why don't we think about obesity as this is a chronic disease and we should be treating it long term? And think about it from a patient standpoint. So they get put on a GLP-1, they get put on tirzepatide. A year later, their blood pressure, they're off their antihypertensives. They're no longer diabetic. And now their sleep apnea is either gone or mostly better. So now they're only getting an injectable GLP-1. That's their only medication now. And why wouldn't that patient want to use it long term? Because you know what? That's a lot easier than having to go back and taking my antihypertensives and my diabetic medications and my CPAP machine. So I'm not sure where this is going to go, and I'm not sure insurance companies are going to let you do that. But because all of a sudden you've lost the weight, and I've already seen that they said, well, you've lost the weight, you don't need it anymore. But that makes no sense to me, and from a model standpoint, from an algorithm. So I don't think we know. And I agree, it's sort of the elephant in the room kind of question, but my sense of this is that this may be long-term therapy and you won't go off it. Your weight will stabilize. And just like any chronic disease, obesity should be thought of as a chronic disease. And then there's a whole nother aspect, which you didn't ask me about, but should we prevent obesity? So let's say you've got a BMI of 28 or 27 and your parents have BMIs of 35 and you're 30 years old or 35 years old and you know where you're headed. You're headed to being like your parents. Well, why do I have to become obese before I can be treated? Why don't I get put on these medications to prevent me from ever developing obesity and all the complications from it? So I think that's a whole other aspect here, is that should we be using these medications to prevent obesity? But to answer your question succinctly, I think there's going to be a lot of patients who stay on these drugs long term.
Yeah, I guess we'll have to see. But yeah, I think you made a lot of really great points there, especially with the preventing obesity. You know, if you obviously an ounce of prevention is worth a pound of cure. I wish that the insurance companies would see it that way. But I think that's an excellent idea. And yeah, I mean, if you have an AHI of 5 and you're young and your weight is increasing, maybe that would be an indication to start a medication right there too, to keep it from getting worse or to keep some other sort of disease state from progressing. I think that's an excellent idea. We've talked about a lot of positive aspects that might be coming from, the use of medications for sleep apnea. Are there any things that you're worried about, or are there any concerns that you have, or any negatives that you see?
Yeah, I mean, and we're not prescribing them yet, so I think I'm probably not the best person to answer this, but there's GI side effects. You have to worry about pancreatitis, nausea, vomiting, diarrhea, the whole 9 yards. There's some unusual cancers you have to worry about. You do have to worry about this muscle loss and some of the changes that potentially would occur, not so much in the pharynx, but just in terms of falling, or if your muscles get weak. So I think you have to pay attention, and insurances aren't all going to cover it. But my experience so far is, and these are patients, and probably about 40% of the patients that I see could be on them, already are on them. And in general, the patients like them. They love the fact that they lose weight. They feel better. Everyone compliments that they look better. So they're psychologically in a different space. And then their blood pressure starts getting better and diabetes starts getting better. And we're starting to see their sleep apnea get better, and we're repeating it. So I am worried about side effects, and yes, it's going to be some of the issues. And I'm also really worried about disparity issues, because I'm not sure if you don't have good insurance, you're going to be able to get these medications. And that's not a good answer. I mean, that's probably if you think about people who are economically not in such great shape, they often are the heaviest people, and they're eating at fast food places. And that may be the group that most needs these medications. So I think that I worry about a lot. And who's going to pay for that? But yeah, I think it's like every other medication. Once you start to prescribe it, you're going to look for certain side effects and pay attention to it. You can't just put somebody on these and leave them alone. But I think if you do your due diligence, you're going to be fine.
Is there anything else that I haven't asked you about that you think is important or that you want to mention?
Yeah, I do think it's going to change how we manage CPAP. Part of it is people with really mild sleep apnea, AHI of 5 to 15, are in that range, and maybe that's a third. And then they don't usually get put on CPAP anyway, unless they've got really significant symptoms or atrial fibrillation. And the severe group in AHI over 30, they're going to get these CPAP anyway, because the GLP-1s, maybe they're going to work in a year, but they're not going to work acutely. So you don't want to put that person at risk for a year of falling asleep driving or heart attack, et cetera. But the moderate group, the AHI of 15 to 30, is interesting. And I think most of those patients will still get started on CPAP. But a year later, if their AHI, let's say, started out with an AHI of 22, and now it's down to 11, are they still going to need CPAP? And I think a lot of those patients are going to come off. So I do think, from a CPAP standpoint, there'll be the people who start off with moderate sleep apnea, who typically now get CPAP. They may get it still if they're symptomatic, or they may still get it, but I think a year later, they're not going to need it as much. So I think there's going to be a big change in terms of how we manage sleep apnea, at least in the moderate group. Again, the caveat being there, will patients stay on it long term? If they come off it and they gain the weight back, they're still going to need CPAP. But I think that's going to change how we manage patients.
Yeah, I agree. I think, for that, especially that lower end of moderate group where you're like, if you could just lose like 20 pounds, you wouldn't even need this. I think it might have the most like immediate impact on that group. I mean, I could see that really changing how we counsel people, especially in that range of severity. Well, all right. Thank you so much for talking with me today and for, sharing all of this great information. It's a, really exciting topic, and it's going to be really interesting to see what happens with clinical practice and with our patients and everything in the future. I think this is really, really going to change a lot. So I don't know, maybe we'll have to meet next year and do an update.
No problem. I would agree with you. This might be a yearly kind of an update. Totally agree.
Right. Exactly. Well, it seems like things are changing so fast, and there's all these new medications getting improved, and even new devices and new implants and everything. I was just reading about proximal hypoglossal nerve stimulation now, so I was kind of anxious to see what's gonna go on with that. But I don't know. It's a certainly exciting time.
This was Dr. Kara Dupuy-McCauley and Dr. Richard Schwab. We invite you to the 14th annual SASM meeting, October 18th at the Marriott downtown Philadelphia. For more information, check the website sasmhq.org. Thank you.